Hello everyone, this is Osama Naga. We'll start research and statistics. We'll start with a case scenario. You are participating in a cohort study to determine the prevalence of hypertension in children under the age of 10 with a BMI of 98 percentile or above. The study includes 20 pediatric clinics, and not all blood pressure machines are calibrated for children. Which form of bias would it be? Confounding bias, observer bias, recall bias, procedure bias, or measurement bias? Correct answer is measurement bias. Why? Because the blood pressure machines that are not calibrated for children will give wrong results, and this will make the study inaccurate. And in the next few slides, we'll learn about common types of bias. Bias. Bias simply constant errors or systematic errors in a study design or data collection. And because of these errors, you will have inaccurate results. Our goal in this presentation to learn about different types of bias or common types of bias and how to avoid them. Confounding bias. Confounding bias is bad, and we have to learn about it to avoid it in any study. Confounding bias occurs when an association between an exposure and an outcome is distorted by another variable. For example, you are studying the relationship between drinking coffee and heart disease. The confounding variable here is smoking, because most of the people who smoke drink coffee. So you have to consider smoking when you are studying the relationship between drinking coffee and heart disease. Another example, you are studying the relationship between smoking and lung cancer. The confounding variable here is exposure to environmental toxins, because this also can cause lung cancer. So you have to consider the exposure to environmental toxins if you are studying the relationship between smoking and lung cancer. How to reduce the confounding bias? By matching patients. This will reduce the bias. Hawthorne effect. Hawthorne effect simply means the desire or tendency of people to change their own behavior when they are observed. In research, occurs when the subjects of the research study change their own behavior during the study. For example, you are conducting a study, the relationship between smoking and lung cancer. Some people in the smoking group may stop smoking during the study. This is called the Hawthorne effect. Measurement bias. Measurement bias means that the data is gathered in a systematically distorted way, meaning that the measurements are wrong most of the time. For example, using inaccurate thermometers, inaccurate scales for measurement of weight, using, for example, blood pressure machine not calibrated for children. So measurement bias is constant faulty measurements, and this of course will affect the result of the study. Start a new section, study designs. Randomized controlled trials. This is the best study design. This is the gold standard to evaluate risks and benefits of a new treatment. Randomized means no selection bias, means different ages, different genders. Controlled. That's why this word came from. We have a control group. Control group is the one who will be receiving the placebo. And the treatment group is the one who will be receiving the new treatment or the active drug. And we have to have both groups, the treatment group and control group, very similar or very close to each other in terms of ages, genders, education, disease history. They have to be close as possible or no major differences. Again, to emphasize, in randomized controlled trials, the best to be double blind. It means neither the subjects nor the researchers know which one is using the active drug and which one is using the placebo. Cohort studies, very important to be familiar with, is widely used. Will evaluate the relationship between exposure and outcome, between risk factors and outcome of a disease. We'll take smoking as an example. We have two groups of people, smokers and non-smokers. Then we'll follow them up over time as a prospective study over 10, 20, 30, or even 50 years, and we'll see who will develop ischemic heart disease over time at the end of the study. The disadvantages of this study is time consuming, is expensive. Also, confounding variables are common or biased because this group of people who are smokers may, for example, drink coffee or likely will be drinking coffee. So the coffee here will be the confounding variable. Also, Hawthorne effect, they may change their behavior. Some of the smokers may stop smoking, some of the non-smokers may start smoking. Again, cohort studies are prospective studies. Case control studies are retrospective studies. Both of them are observational studies. Cross-sectional studies. Cross-sectional study is a snapshot study of data collection at a specific point in time. It is quick, easy, no need for long-term data collection like cases of cohort study. It will give you information what is happening right now. You can collect information like gender, ages, health status, education level, demographic, and risk factors like smoking and disease status with or without disease. Again, to review the different study designs we reviewed so far, cohort study is a prospective study. Case-controlled study is a retrospective study. Cross-sectional study will give you information what is happening now at a specific point in time. All of them, they are observational studies. We'll study the prevalence, and also very important to know that all of them, they are at risk of presence of confounding variables. Incidence and the prevalence. Incidence means new cases, new diseases in the community. Prevalence means how many patients have the disease in the community, means the burden of disease in the community, prevalence. Simply, prevalence equal incidence plus duration. How long does the disease last? The outcome of any disease, either cured or the patient died from the disease. If the patient is cured, this will decrease the prevalence. If the patient died, this will decrease the prevalence. If the incidence of disease increased, the prevalence or the number of patients with disease will increase. Let's understand the difference between incidence and the prevalence in a very simple way. I will use the numerator only to make it easy to understand, the top number. You work in a hospital in the month of January and you received 3 new admissions. Red means a new admission, black means still in the hospital. So patient 1, 2, and 3. So your incidence in the first week, your new admission, your new cases, the incidence is 3 and the prevalence is 3 equal. In the second week, the prevalence is still the same. None of them discharged, none of them died. And your incidence is 0. You don't have any new cases or new admission. In the third week, you have your prevalence is only 2. Why? Because patient number 1 cured already, was discharged. And your incidence is 0 because you do not have any new admission in the third week for any patient with pneumonia. On the fourth week, your prevalence is 2. Why? Because your patient number 1 already discharged, patient number 2 discharged, and the patient number 3 still there. This is 1. And you have a new admission with pneumonia. So you have a new case with pneumonia. So your incidence in the fourth week is 1 new case, and your prevalence is 2. I will conclude the discussion about prevalence and the incidence in this slide. Very important to know that prevalence will be greater than incidence in chronic conditions. For example, you have 5 new cases diagnosed with tuberculosis in your community. Plus, you have 100 cases of tuberculosis being treated in your community. So the new cases are 5 plus the current cases 100, so will be equal 105. So the prevalence here will be 105, but the incidence just 5. So in chronic condition, the prevalence will be more than incidence. On the other hand, prevalence and the incidence will be about the same in acute conditions. For example, you work in a hospital and every day you have about 20 new admissions of RSV bronchiolitis, 20, and you discharge about the same almost every day. So the incidence and the prevalence here is about the same in acute conditions. Now sensitivity and specificity. Sensitivity measures who truly have the disease, true positive. Specificity measures who truly doesn't have the disease, true negative. The first step to learn how to calculate sensitivity, specificity, positive and negative predictive values to learn how to draw the four-square model. The top part is positive, the bottom part is negative. So negative, negative, positive, positive. So positive and positive, this is true positive, and the opposite here will be true negative. Of course, here the top part positive, this will be false positive, and the bottom is negative, so will be here false negative. Again, here is true positive, here is true negative, and the top part here will be false positive, and here will be false negative. What is false positive? False positive occurs when the test reports a positive results for a person who is disease-free. False negative. False negative occurs when the test reports a negative result for a person who actually has the disease. How to calculate sensitivity? Very easy. You will take this portion of the four square and you drop an arrow like that. Will be true positive because you are calculating sensitivity, true positive divided by true positive plus false negative. True positive divided by true positive plus false negative. So do you calculate a specificity? You will take this portion of the four square, and this is the true negative because you are calculating a specificity. You will take the true negative and you drop an arrow divided by true negative plus false positive. Sensitivity. What is sensitivity? Is the probability of correctly identifying those who truly have the disease. So how to calculate sensitivity again? True positive divided by true positive plus false negative. So true positive divided by true positive plus false negative. So a high sensitive test helps rule out disease because the higher the sensitivity, the lower the number of false negative. To emphasize a specificity measures the true negative. So probability of correctly identifying those who do not have the disease, true negative. A highly specific test is used to confirm disease after a screening test and rules in the disease because the higher the specificity, the lower the number of false positive. The higher the sensitivity, the true negative, the lower the number of false positive. How to calculate positive predictive value? You will take the top part of the four square. You are calculating positive predictive value. You will take the true positive first. You drop the arrow. So it will be true positive divided by true positive plus false positive. So remember, in positive predictive value, everything will P, everything positive. True positive divided by true positive plus false positive. How to calculate negative predictive value? We'll take the bottom part of the four square and we are testing negative predictive value. We'll start from here, true negative divided by true negative plus false negative. So remember, in negative predictive value, you have n, all negative. True negative divided by true negative plus false negative. Let's understand the meaning of positive predictive value. Positive predictive value is the likelihood that a patient with positive test is truly positive, is having the condition, is having the disease. Predictive values are dependent on the prevalence of the disease, means that the higher the prevalence of a disease, the higher the positive predictive value of the test. On the other hand, the negative predictive value is the likelihood that a patient with a negative test is truly negative, is truly that this patient doesn't have the disease. Let's summarize what we have discussed before. Very important before the exam, you have to know how to calculate sensitivity, specificity, positive and negative predictive values. Let's start with sensitivity. Sensitivity means true positive, then divided by true positive plus false negative. So you will take this side of the 4 square, the left side. So again, true positive, because sensitivity, divided by true positive plus false negative. Specificity is the opposite. So specificity, you start with the true negative, divided by true negative plus false positive. Positive predictive value, you will take the top part of the 4 square, and because you are doing positive predictive value, you start with true positive divided by true positive plus false positive. Negative predictive value, you'll take the bottom part of the 4 square. Because you are doing negative predictive value, you start with true negative divided by true negative plus false negative.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.